Hi, everyone. Welcome to the Nutritional Needs for Patients Living with IBD, Part 2 with Drs. Park and Shanmugam from UCI Digestive Health. We'll be beginning in just a moment, so we're giving some time for everyone to get settled and sign on. So thank you for joining us this evening, and we'll be beginning the program in just a bit. Hi, everyone. Again, my name is Tiffany. I'm the Executive Director for the Greater Los Angeles and Orange County chapter. For those of you that are new to the foundation, our chapter serves Los Angeles, Orange County, San Bernardino, Santa Barbara, Ventura, Kern, and San Luis Obispo, as well as the lovely state of Hawaii. We have over 220,000 patients that we serve and support. And during this year's Crohn's and Colitis Awareness Week, we are just so grateful to have all of you join us tonight in helping us make IBD visible. Millions of Americans live with Crohn's disease or ulcerative colitis, and from December 1st to the 7th, the Foundation has designed a really special program this week to bring together the IBD community around a shared goal, which is to raise awareness and educate the public about IBD. And as part of our mission to see a future free of Crohn's and ulcerative colitis, we will be hearing from some fantastic speakers today. And it is my pleasure to be introducing to you the first speaker, which is Janet Jones. She is our South Bay Support Group co-facilitator. Janet has been doing such incredible work in leading our support group, and I can't wait for you to hear more about her story and how much the South Bay Support Group has done to improve the quality of life for so many of our patients and their loved ones. So kicking it off to you, Janet.
Thank you so much, Tiffany. I'm so honored to be part of this panel discussion tonight and to represent the CCF South Bay Support Group, which I've been a part of now for 15 years, which is a very long time. I joined the support group like 16 years ago, and that was because I do not have Crohn's, I do not have colitis, but my son, Evan, my older son, was diagnosed with Crohn's at age 14. He is now 32, but I can tell you, I'm sure many of you will relate to this, that his diagnosis turned our family completely inside out. We didn't even know what Crohn's disease was. We didn't know where to go, what to do, who to talk to, who not to talk with. It was a chaotic time, and in some ways still continues to be. That said, the moment for me came when Evan walked into my room. It was several weeks after he was diagnosed, and said, "Are you telling me this thing is forever? It's not like the flu and it goes away?" And that was a startling moment for me too, to realize we were going to have a big mountain to climb. So it has been difficult. I'd be lying if I said otherwise, but the good news is that I wanted to become a co-facilitator in a support group because I felt that I could bring to it some form of sanity for the people who would come to the support group and not know who to turn to, what to do, how their feelings were so out of whack. So that's what I think of my role, is to kind of alleviate both the patients' anxieties and those of their loved ones, because Crohn's and colitis are family destroyers in so many ways. They affect everybody. And so I believe that our support group, which I co-facilitate with Gary Hirschhorn, really gives patients a chance to just let their hair down, to be understood in an environment where people do understand them. I think so many Crohn's patients feel like they're in an English-speaking world but they're speaking Swahili, that nobody really understands them. But when they're at our support group, we understand them, we support them, we encourage them, we give them information, and we let them know, my gosh, you're not alone. We're here, both at the support group, you can call us afterwards. So Gary and I have witnessed, seriously, hundreds and hundreds of patients and their families whose lives honestly have been impacted in great ways just by being there and sharing whatever it is they've got on their mind. So that has been very gratifying. I hope any of you who might be interested in a support group will seek one out. I can assure you it will benefit you. And I want to make one final note. I mentioned my son Evan was the reason that I joined and became a co-facilitator. And I'm happy to say that after he graduated from USC, he went into the entertainment industry, and no surprise, his system was just out of whack because of it. So he took it upon himself to go back to grad school and change his whole life. And he is now a therapist who specializes in clients with chronic diseases like his. So like the panelists tonight who are doing so much to make life better for all of us involved with IBD, Evan is doing his part as well. So thank you all for letting us be here tonight to represent the South Bay Support Group. And now we're back to Tiffany.
Thank you so much, Janet, for sharing your story. The Greater Los Angeles and Orange County chapter has over 12 support groups. So please, in the link below in our chat box, you can see that you can join a support group near you. Many of them are virtual. So surround yourself with a supportive community with incredible facilitators like Janet here. And before we begin, I just want to remind you that we do have a wonderful Q&A portion at the end of the evening. So make sure to plug in your questions in the Q&A box below. The chat is disabled, but please, again, the Q&A portion will be a really wonderful time for everyone. So please be sure to enter your questions in during the program. So I want to introduce to you now our speakers tonight. Dr. Stanmugen is a colon and rectal surgeon, and Dr. Park is a gastroenterologist, and we are so grateful for our partnership with UCI Digestive Health this year for Crohn's and Colitis Awareness Week. So I'm going to kick it off to Dr. Sandra Park to begin this tonight's presentation.
Thank you so much, Tiffany, and thank you to the Crohn's and Colitis Foundation for this invitation. Next slide. Next slide. Okay, we're going to be talking about malnutrition and IBD and the different diets in inflammatory bowel disease. So inflammatory bowel disease, which includes Crohn's disease and ulcerative colitis, are chronic immune-mediated conditions that cause inflammation of the GI tract. And the pathogenesis of this condition is hypothesized to be the result of an interplay between genetic susceptibility as well as environmental triggers that then results in an aberrant response by the immune system, which results in chronic disease. And oftentimes patients who are diagnosed with this condition, view diet as one of the environmental factors that plays a role in not only the development of this disease, but the disease course, as well as the treatment and therapy of IBD. Next slide. So adults with IBD have an increased risk of malnutrition, and malnutrition is defined by the Aspen criteria as an acute, subacute, or a chronic state of nutrition in which varying degrees of nutrition, with or without inflammatory activity, have led to a change in the body composition and diminished function. And malnutrition is reported anywhere from 40 to 70% of hospitalized patients and 20 to 40% of outpatient IBD patients who come to our clinics. And it's important to understand and identify malnutrition because having malnutrition is associated with increased mortality. There's a higher risk of infection when patients are malnourished. There's also a higher risk of medication failure and thromboembolism or blood clots. Adults at risk for malnutrition are defined by adults who have an involuntary loss of 10% or more of their usual body weight within 6 months, or an involuntary loss of greater than or equal to 5% of their usual body weight over 1 month. Also, patients who have a BMI of less than 18.5 or greater than 25, adults with chronic disease or increased metabolic requirements, or adult patients who have altered diets or altered diet schedules, they may all be at risk for malnutrition. Next slide. Patients with IBD develop a reduction in lean mass over time, and this may possibly be due to a chronically poor dietary intake, increased protein turnover, and gut loss of nutrients during active flares of disease, and decreased eating. So corticosteroids, which are oftentimes used to treat patients, can increase the loss of protein, especially in Crohn's disease. Food avoidance by patients and restriction in diet can also worsen nutritional status. And although the daily protein needs of IBD patients are similar to patients without IBD when they're in remission, the needs of protein increase during active flare due to the catabolic response that occurs during active flares. And sarcopenia is a term that's defined by this depletion in lean muscle mass. And not only is it the depletion of muscle, but it's also a loss of muscle strength. And patients with sarcopenia have an increased risk of postoperative complications as well as morbidity. And you can see down below on the photo here, on the right, you have a patient who does not have sarcopenia. They have regular muscle mass. But then on the left, you see in purple, you can see that this patient has sarcopenia. They have loss of muscle, and the amount of muscle is a lot less than the patient on the right. Next slide. So micronutrient deficiencies are important to identify. Gut loss and inadequate dietary intake may cause these micronutrient deficiencies and trace element deficiencies. This is a slide derived from the Crohn's and Colitis Foundation website, courtesy of Kelly Isaacson. And some of the micronutrient deficiencies that are identified in IBD patients are calcium. For example, patients who have a vitamin D deficiency or on chronic corticosteroids may have a depletion of calcium, and that can cause muscle cramping, it can cause seizures, EKG changes. Patients with cobalamin or B12 deficiency can occur, especially in patients who have Crohn's ileitis, because B12 is absorbed in the terminal ileum. Patients who have a resection of greater than 20 centimeters of the terminal ileum or who are vegetarian may also have a deficiency in B12. And that can cause anemia, it can cause confusion or memory problems. Vitamin D deficiency is also something common we see in patients with Crohn's, or you see patients who have malabsorption who may have SIBO or small intestinal bacterial overgrowth. Patients on chronic corticosteroids can develop vitamin D deficiency, and that may cause low calcium, it may cause bone loss, and it may cause bone fractures. Folate deficiency or B9 deficiency can occur as a result of some of the medications that we use in our patients, like sulfasalazine or methotrexate, so it's important to supplement, and that can lead to anemia or diarrhea. Iron deficiency is something we see commonly among patients with IBD. This can occur as a result of GI bleeding or due to SIBO, and that may cause anemia or fatigue. Magnesium deficiency can also occur as a result of chronic diarrhea or short bowel syndrome after having small intestine removed, and this can cause seizures and arrhythmia. Vitamin B6 can cause dermatitis or confusion, and this can occur in patients who have poor oral intake or have chronic corticosteroid use. And zinc deficiency, which is quite important, is involved in wound healing. It's important for wound healing as well as night vision. And this can occur in patients who are on a chronic PPI diet or who are on a vegetarian diet. It's important for zinc absorption. And if you block the acid production, it may get in the way of absorption of some of these vitamins and minerals. Next slide. So there is no specific IBD diet that is generally recommended to promote remission in patients with active disease. And so There is no specific dietary component that's been identified to drive inflammation. So there is no one diet fits all. And evidence-based therapies for reducing intestinal inflammation in patients with IBD include the exclusive enteral nutrition and the Crohn's disease exclusion diet for active Crohn's disease in pediatric patients, which we'll talk about in the next slide. Diets such as the SCD diet or the specific carbohydrate diet, the gluten-free diet, and the low FODMAP diets, they do not have adequate data to show that they can induce remission. These diets can be used to alleviate symptoms, but only a few uncontrolled studies suggest that it may help maintain remission. So therefore, given what we know about these dietary recommendations, patients should receive an individualized nutrition evaluation based on personal dietary needs that are identified by the physician as well as the dietitian in order to personally optimize their diet status. Next slide. So we'll go over some of the popular dietary interventions briefly. Next slide. So the exclusive enteral nutrition diet is a specific diet where you get 100% of your nutrition through a liquid formulation. And this can be given either orally or via a feeding tube. And you give it for about 4 to 12 weeks. And you can see on the picture above, you can see that's the EEN or the exclusive enteral nutrition that's given either through a feeding tube or orally, patients ingest it. This diet is actually the recommended first-line induction therapy for children. So in the pediatric population with acute active luminal Crohn's disease, this is the first-line induction therapy. And the mechanism behind why this works is unclear, but researchers think that this may downregulate the pro-inflammatory cytokines, and they may decrease intestinal inflammation by altering the microbiome. There are 3 enteral formulations that are involved in EEN. There's the elemental, the semi-elemental, and the polymeric protein diet. And all of these formulas are about equal in terms of efficacy. The efficacy of EEN versus corticosteroids, unfortunately, the data is pretty mixed in the adult population, although we have positive data for the pediatrics. In adults, it's quite different. There are some studies that show that EEN may be helpful, and then there are other studies that show that actually corticosteroids are more helpful. And so the results are quite mixed, and that's why we don't necessarily go to this in adult patients. So EEN is well studied. It's a well-studied dietary intervention in pediatric, but we do have to do further studies to see whether this is effective in adult patients. Next slide. So the Crohn's disease exclusion diet, or the CDED, improves dysbiosis of the gut by modifying carbohydrates. So we reduce lactose and processed carbs. We reduce animal fats and sugars and additives, and increase soluble fibers and certain types of probiotics. And we encourage patients to take in more lean meats, poultry, fish, and probiotics in the form of soluble fiber, such as banana, oats, and flax. And dietary and dairy intake is limited. We tell patients not to do the dairy. This type of diet is better tolerated than its alternative, which is the EEN diet, which we just talked about. It's a little bit more palatable. And the CDED diet comes in phases. It's like there's 3 phases to this specific diet. The first phase, you're on this diet. It's called the partial enteral nutrition diet because you're doing the enteral nutrition for about 50% comes from formula, and then the other half of it comes from allowance of certain types of foods that don't trigger inflammation, and this is given for about 6 weeks. That's the first phase. Then in the second phase, you allow certain foods while you reduce the partial enteral nutrition. And then in the third phase, you have more liberalization of food choices and no formula. And some of the trials in the pediatric patients in mild Crohn's disease do show higher rates of response and steroid-free remission. But again, the data is a little bit mixed with the adult population. Next slide. The Mediterranean diet, as we know, is a diet that's used to treat cardiovascular disease. It's been known to improve fatty liver as well as depression. And this diet is a diet that's high in omega-3 fatty acids and low in omega-6 fatty acids, because some of the omega-6 fatty acids have been implicated in inflammation. And so it kind of helps to balance out that ratio. And this diet is high in vegetables, fruits, and whole grains. It's moderate in fish, beans, and eggs. And basically you limit red meat intake. And randomized controlled data show that this diet can lead to symptomatic improvement in a similar proportion of patients, just like the SCD diet, which we'll talk about next. But although it improves symptoms, there's little evidence to show that it actually reduces intestinal inflammation. Next slide. So the specific carbohydrate diet assumes that intestinal disorders are caused by overgrowth and imbalance of these pro-inflammatory gut microbes, that occur as a result of ingesting these poorly absorbed carbohydrates that wreak havoc and then cause symptoms. And so patients are advised to avoid grains, wheat, barley, corn, processed foods, and milk. And some of the foods that are permitted include fresh vegetables and fruits, like bananas, meats, and yogurts and nuts. And patients are encouraged to eat a carbohydrate diet that's actually really easy to help with absorption so that you prevent imbalance of these pro-inflammatory microbes. And most studies, once again, are done in the pediatric patients with Crohn's disease. And the SCD diet does have a pretty high adherence, but more data is needed. With respect to the SCD versus the Mediterranean diet, the SCD and the Mediterranean diets are thought to have a potential to improve IBD symptoms based on some of the case series that have been done. And as we just talked about, the Mediterranean diet is known for its overall health benefits, not just for GI, but cardiovascular. There is a study done by Lewis and colleagues in 2021 that was published in 2021 called the DINE-CD study that showed that after 6 and 12 weeks, both the Mediterranean as well as the SCD diet helped patients achieve symptomatic remission. And both diets actually helped to reduce fatigue, it helped with pain, it helped with sleep disturbances. And in that trial, the Mediterranean diet was better tolerated. And although both diets helped to achieve symptomatic remission, the inflammatory markers, unfortunately, did not improve. So they also looked at CRP and fecal calprotectin. And although the SCD diet did trend towards a decrease in fecal calpro for the first 6 weeks, by the time 12 weeks hit, it went back up. And so we're not really seeing the CRP and fecal calprotectin response, but the patients are actually noticing improvement in their symptoms as a result of either of these diets. Next slide. The low FODMAP diet, which is a diet that you've heard of very frequently. This diet basically advises patients to avoid carbohydrates that are poorly absorbed, that can later ferment in the intestines by bacteria that then result in increased gas production. And it goes in 3 phases. The first phase is to eliminate all the foods that are actually under the high FODMAP category. And then after you eliminate them and get relief, you slowly reintroduce some of the diets that you can actually tolerate. And then you go into the maintenance phase where you identify some of the foods that you're able to tolerate and then continue diet. The low FODMAP diet is a pretty restrictive diet. So for patients who may have nutritional deficiencies or who may have eating disorders, this may not be the best option. However, studies show that patients do notice an improvement in symptoms of bloating, pain, and diarrhea when they adhere to this diet. It's just that this diet, once again, just like the other diets, do not show any effect on fecal calprotectin. It doesn't really appear to impact inflammation of the gut per se. Next slide. So in conclusion, with regards to diet recommendations, counseling with a dietitian is helpful to improve nutrition therapy and to avoid malnutrition in not just active disease, but in all stages of IBD, whether you're active or in remission. Exclusive enteral nutrition has been shown to be helpful for active Crohn's disease in pediatric patients, but among adults, the data is inconsistent. Further studies need to be done. There is no specific diet that needs to be followed during remission, but individual food intolerances may be present, and it's different for everyone. There are some patients who may have lactose intolerance, some patients who don't like fried foods and they have intolerance. Diet trends help alleviate these GI symptoms, but it does not directly affect inflammation itself. And so a healthy, individualized, tailored diet is the best thing that can optimize nutrition status. Thank you.
Thanks, Dr. Park. Hello, my name is Skandon Shanmugam. I'm a colon and rectal surgeon here at the University of California, Irvine. I'd like to begin by saying thank you first to the Crohn's and Colitis Foundation for this opportunity to speak, but really for all the amazing work that the foundation has been doing. I've been a colorectal surgeon for about over 10 years now with a robust experience in IBD surgery. And I can unequivocally say that the foundation has really been a silent partner in helping me manage IBD patients. And I think one of the takeaways here should be to join, support, and utilize this website and its support groups, because it really has been life-saving resources to some of my patients. Next slide. Next slide. While I hope, one slide before this, thanks. So while I hope that none of the IBD patients online would require my services as a surgeon, it is important to understand the role of adequate nutrition, or more specifically, the lack thereof as it pertains to surgery for IBD. And unfortunately, there is a very common interplay of inflammatory bowel disease and the need for surgery and malnutrition. So we know that IBD can cause inflammatory response within the lining of your GI tract, which in turn can cause a patient to experience pain, nausea, and diarrhea. So it's no surprise that these symptoms lead to a decrease in appetite and absorption. And it's approximated that almost 85% of IBD patients, especially with moderate to severe disease, will in fact be malnourished. And what we can juxtapose this state of malnutrition with the risk of surgery, which is approximately 50% in patients with Crohn's disease and 40% in patients with ulcerative colitis. These numbers may actually seem pretty drastic, but they're actually much improved than they were 10 years ago, probably due to the new advent of all these medications that's out there and maybe some improvement in controlling the disease medically. Next slide. It might be useful to discuss the indications for surgery in IBD, which can really be grouped into these two categories. Compared to the general population, patients with IBD can develop a 2 to 3-fold increased risk for colorectal cancer and precancerous polyps or dysplasia. So I can't emphasize enough the need for screening colonoscopy in these patients and the importance of following through with the recommendations of your gastroenterologist. The more common indication for surgery is for medical refractory disease, or when a patients are unable to tolerate medical therapy because of side effects, or if they were to become non-compliant. Now, this can result in several phenotypes that you kind of see highlighted in these pictures. Some of these phenotypes within the GI tract, such as severe inflammation and strictures, or the narrowing of a lumen of the small intestine and colon. An infection that develops outside the lining of your tract, or an abscess, can also develop, along with what we call these tunnels or fistulas that form around surrounding structures, whether it be to the small bowel, the large bowel, or even other structures like the bladder and so forth. In more profound cases, a patient may develop toxic colitis, an obstruction, or even a perforation, all of which can be a clear-cut indication for surgery. Next slide. As mentioned before, upwards of 85% of patients that require surgery for IBD will be malnourished. And how can we know this? Well, perhaps the easiest way to assess this is through a thorough physical exam and a history. As you can imagine, as the disease progresses into any of these intestinal manifestations we showed before, such as a stricture or an abscess, it's only natural for a patient to lose their appetite or develop a food fear. And therefore, we can physically see a patient losing 10% of their weight or drop their body mass index to concerning levels over a period of time. Other more objective data can be gained by testing some of these nutritional markers within the bloodstream, such as an albumin and prealbumin. Some studies have shown that these are less reliable in the setting of active inflammation, but it's nonetheless, in my opinion, the best marker we have, especially if we were to trend these over a period of time. Next slide. Over the last 20 years now, we have accumulated some convincing evidence that preoperative malnutrition can have some drastic consequences after surgery, from an increased surgical site infection rate to sepsis. As it pertains for surgery specific for IBD or in Crohn's disease, for example, there is an increased risk of preoperative malnutrition can increase the length of bowel that needs to be resected. It can increase the risk of a leak after anastomosis or reconnection that needs to appear. And a patient with severe malnutrition are more likely to have an ostomy after surgery as well. Next slide. Thank you. And so there are a few nutritional interventions that we would recommend for malnourished patients prior to surgery. The best way, of course, to boost your nutrition is via the enteral nutrition or by mouth. Working closely with the dietitian, a patient's specific protein, caloric, and nutrient needs are formulated into a form of a shake, which they can hopefully digest. There are also some commercially available liquid supplements out there like Peptamen, Imodulin, IBD, and Enlive. A more crude alternative form of enteral nutrition is to administer feeds through a tube, either through your nose, your mouth, or directly into your stomach. This, of course, is a bit more invasive, and as Dr. Park mentioned, it has the best results in the pediatric population, where it has been shown to induce mucosal disease remission and decrease surgical complications. The unfortunate reality, of course, is that if I were to see an adult patient as a surgeon, certainly in the hospital, then they are often malnourished with either a stricture, an abscess, or fistula, or an obstruction. So enteral feeds, whether it be by the mouth or tube feeds, are usually not well tolerated. Next slide. In these situations, and especially in the hospital setting, the alternative form for nutrition can be administered intravenously or with what we call total parenteral nutrition. In this situation, a central venous catheter is placed usually at the bedside with sedation by the interventional radiologist, and then a formulated solution is created by a pharmacist based on the needs of the patient. The infusion begins for 24 hours, and progressively over the next 2 to 3 days, the infusion is cycled to either 10 to 12 hours. And sometimes these patients can safely be discharged home with TPN as a bridge to surgery. In addition to supplementing your nutrition, TPN has other benefits, such as allowing for your GI tract to rest and sometimes decrease the level of inflammation, so that at the time of surgery, we can limit how much intestines we need to remove and perhaps even avoid giving a patient an ostomy. Next slide. So what does the scientific evidence show? Well, as you can imagine, it's really hard to do a randomized controlled trial for this, but we have an abundance of retrospective and prospective data that we can extrapolate from. This is just a table, for example, of a meta-analysis that's looking at 29 different studies with over 800 patients with Crohn's disease, all of which found that preoperative nutrition, either by mouth or TPN, has been associated with improved surgical outcomes. Next slide. And so the benefits of seeking medical attention in moderate to severe inflammatory bowel disease and optimizing your nutrition prior to surgery can decrease the rates of wound infections, can decrease the length of bowel that needs to be resected, can certainly decrease the rates of anastomotic leak, and perhaps avoid an ostomy. And so in summary, next slide. And so in summary, malnutrition is once again found in 85% of patients with moderate to severe IBD and can significantly increase the risk of postoperative outcomes. Seeking medical attention with a multidisciplinary team of gastroenterologists, surgeons, dietitians, and pharmacists, so we can help optimize your nutrition prior to surgery, will improve surgical outcomes and greatly improve your quality of life. And I think that wraps it up. So I think we got a few questions that were provided to us online, and Tiffany will chime in if there are more that have been generated through the last few minutes here. And I'm just a surgeon. Dr. Park is much smarter than me, so she's probably going to have better answers to some of these questions. One of the questions provided is, what progress have you seen with the research in curing IBD? Well, as we discussed, there unfortunately is no cure for Crohn's disease. Keep in mind, it's a disease that can affect anywhere in your GI tract, from your mouth all the way to your anus, including other extraintestinal manifestations. Ulcerative colitis, of course, in addition to control with medical therapy, we can perhaps offer some curative approach with surgery by removing your colon and your rectum. But I think the most exciting research now with IBD is probably with mesenchymal stem cells. And these are cells that can be derived either from your bone marrow or adipose tissue. And they can, at least as far as we've studied in animal models, can maybe cause some regeneration in the intestinal tract. And again, this is all very early preliminary study, albeit exciting. There has been some studies injecting stem cells into patients with perianal fistulas with some promise. Neither of these are randomized controlled trials, but it certainly is a pretty hot topic right now. And I think if we were to look in the future, I think stem cells is probably one of the most promising therapies out there. Dr. Park, do you have any? Oh, actually, Dr. Park, this question maybe for you. It says, which new medications for Crohn's disease look the most promising?
So there, just like dietary therapy, I think in terms of medications, not one medication can fit all patients. It really depends on the type of disease you have, UC or Crohn's. It also depends on the phenotype. Do you have fistulizing disease, stricturing disease? Do you have just limited rectal involvement? And so there is no one medication that looks the most promising for any type of Crohn's or UC. There are newer medications that have recently come out, medications such as upadacitinib for ulcerative colitis for patients who have failed anti-TNF. There's also the risankizumab, the interleukin 12 and 23 inhibitors that came out for Crohn's disease. And there are more in the pipeline that are currently undergoing clinical trials and research. So it really depends on the person. There is no one medicine that looks the most promising.
There's another question here recently from the audience. Are all the recommendations, I assume, are all the recommendations and conclusions about Crohn's applicable to UC also? Certainly from the malnourishment standpoint and preoperative preparation, it probably is the same. When it comes to diet, I think Dr. Park can comment, but I feel like some of these diet recommendations may have some benefit with UC and maybe not Crohn's because it's such a chronic condition. Would you agree, Dr. Park?
Yeah, so some of the data on the dietary therapies were done either in Crohn's or UC. So you can't make a blanket statement that covers both UC and Crohn's because they're different. Crohn's involves small bowels, so you may have more malnutrition than UC. But then really sick UC can also develop really bad malnutrition as well. As discussed, the exclusive enteral diet was studied in pediatric Crohn's patients. The data is not as strong for UC when it comes to exclusive enteral nutrition. And so although the pediatric gastroenterologist may use it as, one of the first-line therapies for active Crohn's pediatric patients, they may not necessarily use that as the first line for UC pediatric patients. And some of the other, the popular diets that we discussed have various different data depending on whether you have Crohn's or UC. And so it's not always the same.
Yeah, when it comes to the exclusive enteral nutrition, I always found it fascinating. I came most recently from the University of Pennsylvania, where they had a pretty strong IBD population. And I was actually surprised to see maybe a handful of adults in my practice having or actually tolerating an NG tube or a drop-off. And for those that don't know, those are just tubes that are going into your nose, maybe in a smaller caliber form, with some success. But for the most part, as I think we both mentioned, in the adult population, it's a pretty big ask to have patients insert a tube for, what we think will be 2 to 4 weeks at minimum of therapy. So that's probably why all the data is probably more seen in the pediatric population. Another question here, in regards to taking probiotics, is it true that it's pretty hard to know exactly which strains you may need? So taking it as a supplement hasn't been proven to help if you're not taking the strains you're missing. That's true. I think the data for probiotics is lacking. There really is no randomized controlled trial. The way I approach it with the patient is I basically ask them if they're taking probiotics, if they've noticed a change happen, and if they have, then I say great. And if they haven't, then I would probably have them excluded. If it's not making a benefit, I think it just adds too many, it adds more and more medications and pills for them to take without much benefit. But I think my philosophy of most of this stuff is if it works for you, then so be it. Dr. Park, there's another question here. Is severe arthritis common with IBD?
Yes, so about 30% of patients with inflammatory bowel disease may have other extraintestinal manifestations of their disease. And arthritis is one of the most common extraintestinal manifestations that can occur along with IBD. There are certain types of arthritic conditions, the axial, that may not necessarily correlate with disease, and other types of arthritis that do. And so they are pretty common. Oftentimes, if you treat the underlying Crohn's or UC, the IBD condition, and you treat the inflammation, the arthritis may also get better, but not always. And as you know, there are a subset of patients who may also have IBD with concomitant other rheumatologic arthritic conditions, like psoriatic arthritis or rheumatoid arthritis. And so that requires a different treatment plan than just the biologic that we may be recommending for the gut health. And some of the medications, the biologics that we have available, are better for arthritis than others. And so, and some of them don't really affect arthritis or don't really help arthritis. And so it really depends on the specific biologic you're using. And if you know that arthritis is one of the, one of the major symptoms in a patient with IBD, you may want to choose a therapy that also has data to show that it may be helpful for arthritis. And you may want to work together with a rheumatologist to come together and, see if this is really related to IBD, or whether it's an independent rheumatologic diagnosis that requires a separate therapy from the IBD therapy.
That's a great point. How can patients judge whether over-the-counter supplemental nutrition products like shakes are legitimate? Well, I think the best way to do that is certainly to see a dietitian. These dietitians most often than not have a master's in nutritional science. So there certainly is a science behind it. And they are probably the ones that are most equipped to maybe legitimize some of these shakes or supplements over others. But that's certainly the first step. Speaking of dietitians, I'm a dietitian who has Crohn's disease. I've had a lot of success in reducing flares by cutting out gluten and vegetables in my diet. What do you think about that, Dr. Park?
Yeah, so, gluten-free diet, cutting vegetables out in the diet, they may improve symptoms, just like some of the popular diets that we discuss. But whether they improve inflammation, that is an independent, and the data don't really support that. If you go gluten-free, unless you have celiac disease, then for sure. But if you don't have celiac disease and you're going gluten-free for IBD, thus far, based on the research that's been done, it doesn't support improvement of inflammation at the gut level, endoscopically, as well as CRP or fecal calprotectin, but it may really help with symptoms. So if it helps you, it's okay to do that specific diet that helps you with the guidance of a nutritionist or a dietitian, because certain diets may compromise some of the nutrient intake, and you have to be careful with certain diets so that you're not limiting yourself and being too restrictive with certain diets.
Exactly. Another question. I have a J pouch and try to eat lightly during the day to limit the number of times I need to go to the bathroom. Reasonable. I have a bigger meal in the evening and feel pretty good, but need to use the bathroom a lot during the day when I am not eating much. I have a big smoothie for carbs and protein. Would it be better for me to have something every hour or 3, like a banana? So my approach to patients with J pouch, number one, you're certainly going to lose the absorptive capacity once your colon is removed, and then the reservoir that your rectum once provided us. So patients with J pouch, to be clear, the pouch itself, or the small intestine, becomes more adaptive. So I have patients 5 years, for instance, after a pouch, who have certainly much less frequency and urgency with their bowel habits. So that's something to keep in mind. I'm not sure how long this gentleman or woman has had the J pouch. And then in terms of the diet control, there is an adjustment period, and I don't think any of us kind of take that for granted. What I tell patients is a lot of this is going to be trial and error and timing. and to have made perhaps much smaller meals more frequently and chew your food really well. And the rest in regards to whether you can have a piece of bread or banana really is going to be trial and error. There are other options also, you know, if worse comes to worse, you can acutely manage some of these issues with fiber supplements, I think. The drawback with that is it may add some bloating for patients with J-pouch, but it can certainly add some bulk to your stool and decrease the frequency and urgency, especially at nighttime. And worst case scenario, there's always Imodium. Hope that helps. And then I guess finally, Dr. Park, I'm so afraid of biologics. Is there something safer for a long UC flare?
So, it really, biologics are overall very safe. It's been backed up by years and years of research before the medications do come out. The way I would look at this is if you have a long UC flare that's constantly active, the inflammation is active, and you're not really using the treatment to get the bowel into remission, not only will you have an increased risk of colon cancer, as Dr. Shanmugam mentioned previously, but you're subjecting yourself to multiple courses of corticosteroids, which can actually lead to bigger problems long-term. So not just looking at short-term, okay, well, I don't want to go on biologics, but looking at the long-term, because we know that this disease is a chronic disease, right? Without a cure, long-term, the benefits of biologics do outweigh the risks. Because the alternative is to just do long courses of steroids that actually will lead to bone loss, osteoporosis, and morbidity, poor outcomes in surgery, wound healing issues, So that's the way I would look at it. And I would encourage you to have a long discussion with your gastroenterologist and your surgeon to, think about the pros and cons of therapy and just see what aspects of biologic therapy are so worrisome, because most of the adverse events are really low, and different biologics have different risks depending on the biologic that you would go on.
Great. And then the final question, my teenager is consistently fatigued. They receive infliximab infusions every 6 weeks. They almost do no exercise and used to be very athletic. Besides common sense, is there any data studies for teen with Crohn's? So I think the first thing here is probably what I would recommend is, certainly make sure that your teenager is not deficient in any of the nutritions or anemic. All the things that Dr. Park went over is probably the first thing to rule out. In terms of exercise and Crohn's, I think there's some retrospective studies that engaging in physical activity, at least low intensity activity, certainly will decrease Crohn's disease activity, and perhaps more than anything, reduce such psychological stress. Would you agree with that, Dr. Park?
Yes, certainly.
Yeah. Okay, Tiffany, I guess we'll hand it off to you. I don't see any more questions on the chat unless you're seeing some that I'm not. Thanks.
I think we are all set. Well, I wanted to thank you all so much for joining us this evening, and we hope that you found this webinar to be informative and helpful. We are so grateful for our partnership with UCI Digestive Health, and a huge round of applause for Dr. Park and Dr. Shanmugam in letting both their time and expertise with us. If you would like to have any questions, or if you would like to learn more about the chapter and what we're doing on a local level, please visit us at our website in the chat link below, and you can also email me directly. Thank you again so much for your time, and happy Crohn's and Colitis Awareness Week to you all. Thank you so much, and we'll hope to see you at the next webinar.